حاليا بنتكلم على المانوال كينيتيك ثيرابي. المانوال كينيتيك ثيرابي عباره عن نيو ايمرجينج تكنيك اللي موجود حاليا في نورث امريكا، ابتدى ياخذ اوروبا، ابتدى يخش في افريقيا والميدل ايست. خلينا الاول اتكلم عن نفسي. اسمي زي ما الدكتور رفيق اتفضل، انا اسمي عمرو الجابري، اخصائي علاج طبيعي، خريج دفعه 98، حاصل على البورد الامريكي، البورد الكندي. حاليا عندي الكلينيك بتاعتي موجوده في جريتر تورونتو اريا في كندا. كلينيك اند تريننج، حاليا بدرس التكنيك ده وبعض التكنيكس في الاكيبانشر هنا او في مصر او في السعوديه. ده معظم اللي اقدر اقوله عن نفسي. المانوال كينيتيك ثيرابي عشان نخش في الموضوع على طول. It's a method, a way or method of assessment and treatment of balances between muscles. So we all know، كلنا نعرف ان اي مشكله بتحصل، اي الم بيحصل، اي inflammation في muscle او tendon will create an imbalance between certain groups of muscle or patterns of muscles، وده هنتكلم عليه بالتفصيل كمان شويه. اللي بيحصل حاجه بنقول عليها dysfunctional motor pattern. الديسفانكشنال موتور باترن هو بيبقى نتيجه المشكله او الانفلاميشن اللي حصل، وبيتعزز بالاكتيفيتيز اللي البرين بيعملها. البرين هو المسؤول عن الموتور كنترول بتاعت اي حركه في الجسم. اي motor or learned motor control pattern is from the brain، واي faulty motor control pattern is also from the brain. يعني ايه؟ يعني حضرتك دلوقتي عندنا learned motor pattern، عشان تقوم تمشي تشرب كوبايه ميه تكتب، كل دي learned motor control patterns. طب let's suppose that في يوم من الايام حضرتك قمت نام على كتفك او having a shoulder problem، مش قادر تحرك كتفك، فمش هتقدر توصل لكوبايه الميه، تمد ايدك توصل لكوبايه الميه بتاعتك، فبالتالي الموتور باترن بتاعك هيتغير شويه. البرين will find another way or another method in order to get the job executed. يعني البرين will recruit other muscles so that you can move your shoulder. Yes, it's gonna look weird, it's gonna look different, but all the brain is concerned about is to get the job done, regardless recruiting the correct muscles or incorrect muscles. فده بيخلق حاجه اللي بنقول عليها wrong motor pattern، وده بيبقى المشكله الاساسيه مع معظم الحالات. ان حضرتك بيجي لك المريض بيشتكي من الم في الكتف مثلا، خلينا في موضوع الكتف، بتعمل الاسسمنت بتاعتك بتلاقي مشكله biceptal tendinitis مثلا فور اكزامبل، بس بتلاقي المريض بيشتكي من supraspinatus pain، بيشتكي من scapular muscles pain. طب ايه السبب؟ السبب ان حصل ريكروتمنت للمسلز دي في الرونج باترن ده، او الباترن ده المفروض ما يحصلش، نتيجه الكومبنساتوري ميكانيزم اللي البرين اعتمدها علشان to get the movement going on in the shoulder area. طيب ايه المانوال كينيتيك ثيرابي؟ we use specific protocol. في لينا بروتوكول معين في الاسسمنت، في لينا بروتوكول معين في التريتمنت، في لينا بروتوكول معين في الفولو اب. So we have the assessment, which is halfway to the treatment, then the treatment itself, then the follow-up. These are the main pillars for the manual kinetic therapy. I'll talk about the protocol in details in a few slides from now, but let's talk about how manual kinetic therapy help us to identify and fix imbalances in the motor patterns or imbalances between the muscles themselves. المانيوال كينيتيك ثيرابي، التكنيك اللي احنا بنتكلم عنه، يونيك في حاجه مهمه جدا، ان هو بيساعدك it helps us a lot to identify the core or the root cause of the problem. ايه المشكله الاساسيه؟ المشكله الاساسيه حصلت ليه؟ احيانا المريض بيجي لحضرتك عنده supraspinatus tendinitis، عمل الالترا ساوند، في partial thickness tear في الالترا ساوند results، بس لا العيان اجين بيشتكي لك من الدلتويد، الم شديد في الدلتويد، الم شديد في البايسبس، الم شديد نزل down to the elbow. حضرتك المفروض بتركز في العلاج بتاعك على الفايندنجز اللي هي الالترا ساوند ريزولت، بتقول ان في supraspinatus tendinitis، ده كويس وجميل، بس how about the rest of the patterns? How about the rest of the muscles? You would assume that they will be cured once you fix the supraspinatus, which is incorrect. ليه؟ لأن البرين خلق لك باترن تاني recruited those muscles. The brain recruited the deltoid, the brain recruited the biceps or the brachioradialis. in order to compensate for the instability that is inherited in the shoulder joint or the glenohumeral joint as a result of the dysfunctional supraspinatus. طيب ال MKT بياخدك على طول على الروت كوز اوف ذا dysfunctional. طبعا انت عندك ultrasound results هتقول لك ده الروت كوز اوف ذا dysfunctional pattern اللي موجود عندك، فبالتالي هتقدر تادريس البروبلم based on that. but في احيان كتير ما يبقاش في معاك ultrasound results ومش هتروح تقول للعيان روح اعمل لي ultrasound كل مره يجي لك فيها بيشتكي من الم. الام كي تي هيساعدك ان انت to find the root to find the problem is really in the supraspinatus or the problem is in the infraspinatus or the problem is in the shoulder flexors or extensor. You will go directly and fix the root cause of the problem. هنخش على المشكله، اساس المشكله ونعالجها من الجذور. احنا مش هنقعد نعالج العيان ويجي المره اللي بعديها الالم اتحسن بس رجع تاني، الالم اتحسن بس رجع تاني. ده الفرق ما بين الام كي تي والother techniques. We use corrective therapy, proper techniques. We use activation muscles. Then, hence, the balance will be restored. Symptoms resolution would be confirmed via retesting and movement pattern assessment, which we will talk about in a few minutes. Okay, so why manual kinetic? Why MKT? What is the difference between this technique and other manual therapy approaches? So the huge difference between, like I said a minute ago, manual kinetic therapy technique used to go directly, we use it to go directly to the root cause of the problem. بروح مباشرة على أساس المشكلة. أنت أحيان كتيرة بيجي لك العيان بكذا مشكلة، ما بيجيلكش بمشكلة واحدة. حضرتك بتحاول تعالج اللي موجود. أحيانا السيمتومز اللي عندك، خلينا ناخد المثل بتاع السوبراسباينيتس. العيان عنده سوبراسباينيتس تندينيتس، مفيش تير ولا حاجة. بيجي لك غالبا دي المين كومبلين بتاع العيان، إنه عنده pain في الدلتويد أو عنده pain في البايسبس تندون أو عنده pain again down to the elbow in the biceps muscle. دي symptoms. عادة أنا قبل ما أعرف التكنيك ده وأتعرف عليه وأطبقه في حياتي، أنا كنت هروح على الدلتويد، نعالج الدلتويد، نعمل لها whatever the techniques you want to use. You want to use acupuncture, manual therapy, ultrasound, laser, stimulation, because that's what the patient complained of. But after knowing this is not the root cause of the problem. This is the symptom. ده العرض اللي جاي لك. أنت ما عالجتش أساس المشكلة. هتعالج دي، العين هيروح وهيجي لك تاني الألم قل شوية، بس لما برفع كتفي بيرجع الألم تاني. طب نعمل التمارين الفلانية، طب نعمل كذا. أنت بتعالج السيمتوم اللي العين جالك بيه، وده مش ده المظبوط. في الام كي تي أنا بعرفك بالظبط إيه سبب المشكلة. ليه العيان عنده مشكلة؟ ليه العيان بيشتكي من ألم في الدلتويد؟ ليه العيان بيشتكي من ألم في العضلة دي؟ بتخش على الروت كوز بتاع البروبلم، will fix the problem, then the pain will disappear. You don't need to go directly to the deltoid to fix the problem, but you go to the supraspinatus or the infraspinatus, whatever the compensatory muscle engaged with the deltoid. طيب احنا في الام كي تي بنشتغل على الام كي تي. ده عباره يا جماعه عشان بس الناس تبقى عارفه اتس ليفلز. هو عباره عن كورس طبعا مطول، ليفل 1 و2 و3. في ليفل 1 احنا بنتكلم عن المسلز، البالانسز between the muscles, how to fix the imbalances between different muscles. We talk about the upper extremities, we talk about the core, back, spine in general, and lower extremities. We talk about the neck and cervical muscles. In level 2, we'll talk about patterns, how the muscles work in synergy. We talk about the joints, we talk about specific techniques. And level 3, we'll talk about higher levels. We talk about ligaments, how ligaments are involved, how ligaments are impairing or causing dysfunctional motor patterns. We talk about higher specific techniques like the pelvic floor, the eye muscles, and so on. الفرق بين ال MKT and others ان احنا let's talk about Mulligan, let's talk about McKinsey. They are the most famous techniques used by physiotherapists and broadly used by a lot of physiotherapists all over the world. They focus more in the joints. So if you talk about Mulligan, for example, how to mobilize the joint under movement. If you talk about McKinsey, how to restore the alignment of the joint, which are good, and I still use them, honestly. But when you use the MKT itself, it is a way to tell you if you're really gonna apply this technique and it's gonna work or not. Many times for me, before knowing this technique, I've used to tell the patients, okay, let's do this technique, Mulligan, McKinsey, whatever the techniques I'm using, mobilizations, do it at home, I'll see you next visit. The patient will come, oh, the pain didn't go away, the pain's still there, I'm still in pain. This MKT will give you the tool that when you tell the patient, go home and do this exercise, go home and do this manipulation or mobilization technique, he will come next time saying, I feel much better. And that's the huge difference between this and other techniques. Okay, before going into details about the MKT itself and the protocol and the way we use it in clinical practice, there is a case study that is to come in 10 minutes from now. We'll talk a little bit about the theory, the underlying theory of the MKT, why MKT is used and why it's working. First of all, we will talk about the motor control theory. So motor control is the ability to regulate mechanisms essential to movement. So it is simply how do we move, how do we write, how we run, jump, drive. This is the motor control. So the motor control theory has been like in a lot of debate since like early 20th century, how the body moves, how the brain, we know that the brain gives the order to the motor neuron, now we know, so the motor neurons execute the job and done. It's not that simple. Like psychologists and physiologists, physiotherapists have been trying throughout years to know exact mechanism. Okay, what nerve roots, what are the roots, what are the centers involved in the motor control, so that if we are to know this, we would be able to understand how the brain execute the job or the function, then we will be able to fix this in case if there is an alteration, in case if there is a problem in the nervous system, or in case if there is an issue with the spine or the muscles. There are so many theories that talk about how the motor control is being conducted. The most famous one used by neurophysiotherapists, it's the hierarchical theory, which states that بتقول اللي هي بتستخدم brainstorm. أي حد اشتغل نيورو هيعرف النظرية دي. In higher brain centers control motor patterns. So if you have, if the patient lost any motor control center, the reflexes will be the more prominent and will be like pathological reflexes. There is no bottom up. So ما حدش يجي يقول إن the spine can control the brain or the brain stem or the bones or the medulla. So it's from top to down. It's used, like I said, extensively. It's the foundation of the brainstorm technique used in neuro. But the main thing about it, it can explain of the lower level dominance reflexes, like when you hit a pin or step on a pin or get with the step on something that is painful. There is a reflex. Reflex is, we know all, it's all in the spinal level, and it doesn't explain the motor control. Why you say that the motor control is coming all from the brain while this is not. We have the other theory, which is the motor program theory. And the motor program, let's talk about the second theory, that is the manual kinetic therapy. It's based on, it's called the motor program theory. And before we go there, I'll just talk about the motor program and how it works so that we understand how this works. A motor program, simply, we need it in order for us to execute certain functions. So we will not be able to carry on our life if we, at every single movement, we need to think about it or consider which muscle we are to move. So if I want to walk, I need to think, oh, I need to activate the glutes, I need to get my erectors up, I need to move my arm, I need to activate the biceps, I need to relax the triceps. It doesn't work this way. So the brain will create motor pattern. So it is easier, it's faster to execute, and then it is easily applicable. So everybody in the beginning, like let's say driving a car, in the beginning you will be like paying 110 attention to the surroundings, how you move, how you press the gas, how you press the brakes, how you do this, how you look right, how you turn, how to do all this in the beginning. A month, 2 or 3, you don't need to think about any of this because it is now a learned motor experience, learned motor pattern. دي حاجة خلاص انت اتعلمتها، المخ خلاص, you master the skill, brain will take it and store it in a different level. We call it the CPGs, which is the center pattern generators. That motor program. The center pattern generators are neural circuits that, when activated, produce rhythmic motor patterns. So, like I said, whenever you move, like a learned motor pattern, it is already stored in the brain. If you are to learn a new motor pattern, that's when the brain needs to intervene and execute this new motor learning experience and choose the proper muscles, proper motor neurons to activate in order for this new learned motor pattern to be executed. Let's take an example. حضرتك كل يوم بتنزل العربية بتاعتك، بتفتح الباب، تقعد تدور العربية وتمشي، صح؟ عارف طريقك للشغل، بتاخد الشارع الفلاني، تخش من الشارع ده يمين في شمال، 10 دقايق بكون موجود في البيت. طيب let's assume انت كل يوم ممكن تكون بتتكلم في التليفون، بتفطر، بتشرب شاي وانت سايق العربيه، مش محتاج تفكر في الطريق اصلا اوريدي لان الطريق سهل وواضح. طيب يوم من الايام ماسوره ميه ضربت، بيصلحوا الشارع، عملوا لك ديتور، خلاص حضرتك ما ينفعش تمشي في الشارع ده، تخش يمين في شمال وتلف. اول يوم هتبقى قاعد مركز تماما، انا عايز اخش يمين عشان الفتحه جايه شمال، عشان اخش هنا واروح هنا وابقى اخش على الشارع الرئيسي بتاعي تاني من ورا. ده new learned motor pattern or experience، لازم تكون مركز قوي معاها في الاول علشان تقدر تعملها. اول يوم عرفت بخش هنا، بعد الفتحه دي شمال، بعد الفتحه دي يمين، بخش بوصل هنا في طريق. ثالث يوم، رابع يوم، بعد اسبوع 2 خلاص مش محتاج تفكر اصلا، انت بتبقى تاني هتشرب الشاي وتاكل وتشرب وتتكلم في التليفون وانت بتعمل الموتور، لانه خلاص it is now a learned motor pattern. Once you have a learned motor pattern and the brain mastered it, it will be stored at the level of the central pattern generators. Central pattern generators are very crucial and they are the basic for any human movement now. Actually, they are the foundation of all the research. أنا حضرت سيمينار من حوالي يومين في كاليفورنيا، كانوا بيتكلموا عن إزاي إن هم نظرية السنترال باترن جنريتورز دي. Central pattern generators are the one in charge. So let me assume it or just summarize it for you guys to understand. النظريه بتاع الموتور كنترول بتقول ان السي بي جيز دي عباره عن سيركتس، عباره عن دوائر كهربيه موجوده على الليفل التي سباين and the lumbar spine. We don't need the brain to execute learned motor pattern. احنا مش محتاجين المخ ان هو يدينا الاوردر عشان امشي، مش محتاجين المخ انه يدينا الاوردر عشان to do swimming. And this is research based, by the way. It's not just me saying this. This is research. So a lot of research have been conducted, and the recent one that I've attended like 3 days ago in California, they had people with complete C5 cord, spinal cord compression. So there is nothing at all to be moved from under C5 down. They did the medullary, they did the stimulation, the epidural stimulation for these people at the level of L1, L2, sorry, and for some time. This is a research that's 10 years, extent of this research, 10 years. At the end of the 10 months physiotherapy, epidural stimulation, trying to find the proper configuration to stimulate the muscles, the patient was able to stand up. Again, the patient was able to stand up, complete cord dissection. I can send you the link for the webinar. It is recorded if anyone is interested. And this indicates that we don't need the brain. This is the risk, it's emerging. We don't know exactly how far we can go with that. The brain doesn't need, the movement doesn't need the brain to be executed, especially if it is a learned motor pattern. لو انت اتعلمت المشي مش محتاج المخ بعد كده ان انا اعلمك تمشي، وده الفاونديشن اللي الناس ماشيه عليه في النيورو دلوقتي. الريسيرش اتعمل، ناس كتير عملته لايك مادر بوتشر، الكلام ده بدأ من 1911 تقريبا. لوكوموشن، مش we don't need any brain control. عملوا تجربه مهمه دي كانت الاساس، الجراس هوبر اللي هو الجراد. قاسوا سرعه الاجنحه بتاعت الجراد وازاي بيطير. They measured how fast the grasshopper flies, and they measured how many beats for the wings per minute. Then they cut off the connection between the central nervous system and the spine for that specific insect, and they measured it. They found that it still can fly. The speed is less, the speed of the wings are less, but it still can fly, which indicates that, again, learned motor patterns are stored in a level that's different than the brain. Okay, so these are all research about the motor program theory, how it works, and it all comes to an end that motor control, if it's learned, it's not in the brain mainly, it is in the spine. And that's how we gonna work on learning how to restore. I'm not talking about like complete spinal cord injury stuff, but it is faulty motor pattern. Again, the good motor pattern will be stored at the level of the CBGs at the spine. Also, the faulty motor pattern will be stored at this level. So in order for us to have the brain acquire this learning or good learning new pattern or the alternative new motor pattern, that's where we need to address the level of the CBGs. Okay, so we use certain method or protocol to identify the faulty pattern. So in MKT, we have certain protocol. Again, we have certain ways, certain method of assessing the faulty motor patterns inherited in the area that you are assessing, regardless, the neck, upper extremities, spine, lower extremities, and hence find two groups or two muscles. Always, like to start up with, it is two groups or two muscles that are in this functional pattern. We will identify those two groups. We will prove that they do have a dysfunctional relationship. Always, we have one that is hyperactive or active or facilitated, one that is hypoactive or inhibited or not working. So which one is the active, which one is the underactive? That's what we're gonna talk about. First, we need to know some terminology so that every technique, every method has its own terminology or own experience that everybody should be familiar with in order to facilitate communication. So when we say in this technique, again, we test the muscle connectivity. I'm not manual muscle testing the muscles. I'm not applying so much pressure like grade 3, like all physiotherapists, chiropractors would know that. When I'm testing the muscle strength, like for example, the wrist extensor, we have grade 3 where the patient is able to move. Grade 4, you apply moderate resistance. Grade 5, you apply maximum resistance. In this technique, I'm not doing any of these. I'm testing the connectivity of the muscle at this point to the nervous system. I need to know if the muscle is neurologically active or inactive at this point. And to know that, I just need to see if the muscle connects or not. That's it. So, لما نيجي نعمل اختبار, just you will see me in the practical part. I'm just pushing with the back of my hand, even with my finger. I'm just testing the connectivity. So if I'm testing the wrist extensor, for example, I'm just putting very mild pressure. I need to know if the muscle can meet my pressure or not. I'm not pushing hard to see grade 4 or grade 5 in manual muscle testing. So when I do this and the muscle is weak, it doesn't mean that the muscle is absolutely weak. The patient is paralyzed or the patient is having an issue. No, it is weak at this point or at this position that I'm testing the muscle or in a relationship to another muscle or another pattern. So it is, we call it weak in the clear. That's it. It doesn't mean anything. It doesn't mean that the muscle is not working or the muscle is not functioning. It's just for the purpose of this. It's like when we add subtraction or like simple math equation. If I say 1 plus 4 equals 5, for example. If I say 1, what does it mean? It doesn't mean anything. But if you put 1 plus 4, that means something. If you put 1 plus 4 minus 3, it is another thing. So this 1 that didn't mean anything in the beginning now has a value. And that's how this works. So it is weak. It doesn't mean anything. But if you add it to the equation, if you add it to the protocol that we are going to talk about, it means a lot. It means something different. And that's what we're going to talk about. Again, strong, it doesn't mean that the muscle is strong, it's powerful, the patient can lift weights. No, it doesn't mean this. It means that the muscle is strong at the point that you're testing it. And it's not grade 4, it's not grade 5 plus, all of these manual testing techniques. It's just the muscle is able to meet the challenge to the nervous system at this point. Overactive muscle or facilitated muscle, these are the muscles that we're going to talk about. These are our targets that are neurologically overactive. دي العضلات اللي شغالة زيادة اللي هي حصل overactivation. You'll find these muscles are the tight and painful muscles, mostly tight and painful. So when you find a muscle that is tight and painful, always there is another muscle somewhere that could be painful, but it is weak or underactive or inhibited. So always, or the other way around, if you find a muscle that is underactive or inhibited, there is always another muscle that is overactive or facilitated. And that's where you need to zoom down or narrow down your clinical skills and experience to locate those two muscles or muscle groups and hence apply the protocol that we'll talk about later, and hence you restore the mobility and the pain would be less. Fatigue point is the point where the maximum number of repetitions before the muscle gets tired, or loses the connectivity. Again, you won't be able to get a good result if you keep testing the same muscle over and over again. So if you're testing the wrist extensors, it's like 2-3 times maximum. If you do 4 or 5, the muscle will be fatigued and it's tired. So it doesn't mean anything. It's clinically insignificant. Again, also in the home exercise program that we'll talk about, which is the third pillar of this protocol, it is very, very important to know when to tell the patient to stop the exercise. And that's what you'll test before the patient goes home to the fatigue or prior to the fatigue point. ما ينفعش تدي العيان تمرين بيتعب العيان، ما ينفعش تدي العيان تمرين يجي لك المره يقول لك انا عملت وظهري وجعني زياده او كتفي وجعني زياده. ما ينفعش. طب انا هعرف ازاي العيان يقدر يعمل this amount of repetition؟ هيعرف يعمل 10 مرات، هيعرف 5 مرات، هيعملها بالثيراباند ولا هيعملها بالويت، هيعملها بس against free weight ولا هيعملها ازاي؟ ده اللي هنعرفه هنا. ان انت قبل ما بتبعت العيان before you send the patient home, you will know how many repetitions the patient will do and for how long. So 10 seconds, 3 seconds, 20 seconds, that's what we will discuss. Again, we're testing connectivity, not the strength. This is very important. We have the differential. This is the main thing. This is the bulk of it, which everybody needs to pay like extra attention for that. How does it work? So again, we will find the patient. Let's talk about regular average patient that will come to your clinic every day. We'll talk about the shoulder. It's easier for you guys to see from this. A patient will come to you complaining, let's say, of pain in front of the shoulder. So you'll do your range of motion assessment, you'll do your palpation, you'll do your orthopedic testings. You will conclude that, yes, the patient has a problem in the biceps tendon, which is very painful. Again, usually that's what I would do like 10, 15 years ago. I would go there, start treating the biceps tendon, start manipulating, ultrasound, laser, acupuncture, cupping, whatever the way you want to do it with the patient. And hence the patient will go home, oh, the pain is much less. Next visit, the patient will come, you know what, it was good for a day or two. Once I get back to work, start driving, the pain still there. I can't feel it. It's not good now. It's almost the same, or it's very minimally less than last time. But if I'm start overly using my arm, even reaching up or lifting anything, I can't do it still. Why? If you remember that we said for every active tender muscle, there is an underactive, tired muscle. So in MKT, we will find which muscle paired with the biceps that is not working. So this muscle is painful because it is overworking, it is painful, it is facilitated. So we need to find the inhibited muscle and activate this muscle so that we will restore the balance of muscles around the shoulder joint. We need to restore the balance before we fix the problem. We need to understand how we're going to restore. So before I fix this, that is excellent. That is what every physiotherapist will do. It's very important for us to know which muscle we need to activate. If there is an overactive muscle, there is an underactive muscle. If you send the patient home like this, you just fixed half of the problem. Once the patient starts using the shoulder, he will overly use this muscle because it's an overactive muscle and underuse the other muscle that is paired in this wrong pattern. Again, the brain will choose to get the job done regardless using which muscle. So if there should be a balance between both muscles and due to the injury, the brain recruited the biceps more, the brain focused more on the biceps to get the job of lifting the arm or moving the arm, keep going on. And this is a new, remember, new learned motor pattern. Although it is a wrong pattern, but it is a new learned motor pattern. The brain will keep using it until, okay, that's the new now, that's the norm, then store it at the level of the CBGs. It is now there. So for you as a patient, it's hard to undo this until you restore the balance between those and ask the brain, hey, that's the wrong motor pattern, please correct yourself and start using the biceps in accordance with, for example, the triceps, which is the muscle we found from our protocol paired with the biceps. If you send the patient with this concept, okay, we will release the biceps, we will activate the triceps, and hence we will restore the balance around the shoulder joint. The patient will come to you next visit at least 50% painless. على الأقل 50% if not in the same visit, but that's how I achieve my progress here with my clients. The patient العيان ما بيخرجش من العيادة عندي أقل حاجة لو هي multiple problem. If it's a simple problem like this, 50% of symptoms are gone, at least 50%. العيان بيخرج من عندي 50% من أعراضه قلت. دي لو هي single problem. أحيانا بيبقى فيه في الشولدر multiple issues, which is not the topic of this lecture. We talk about it in details in the courses where we have lengthy time to talk about. Okay, so this is a very simple way of doing it. I'll explain it more once we go for our live case study and explain to you. So we do the proper assessment. We zoom down on the problem. So when a patient comes, most of the patient, if you're lucky, will say, hey, it's here. He will say, you know what, all my shoulder is painful. You know what, I don't know exactly where is my pain. Is it to the front? Is it to the side? Is it to the back? It all hurts, so fix it for me. Okay, so what happened is there is a single problem, like I said, that created the pattern, the faulty pattern. So a muscle that is not doing its job, let's say the supraspinatus, then the brain will start recruiting other muscles like the deltoid in order to compensate, because these are the two muscles that are in charge of the abduction. So the brain will recruit the deltoid, for example, instead of the supraspinatus, but the deltoid cannot initiate the abduction from 0 to 15, like all we know. So what happens is it is all born into the deltoid to do, just do it. The brain said, do it, so you'll have to do it. He's the boss. So once the brain asks the deltoid or order the deltoid to start doing the abduction instead of the supraspinatus, because supraspinatus has a partial thickness tear, it can't do the job. In a week or two, or a day or two, the deltoid will start to be fatigued, start to be painful. So the patient will come complaining of pain here and pain there. If the patient is good enough, he will come early, you'll fix him. But what if the patient is late, a week or two more? Then the deltoid is tired. The deltoid can't do the job. Then the brain will recruit other muscles. Okay, have the biceps, long head of the biceps. It is strong. It is attached to the acromion. It can provide more stability to the shoulder joint. Recruit it in terms of abduction. Try to stabilize the shoulder joint. So now the biceps started to do another job. Instead of just flexing the arm, it's supporting the joint in abduction, which is not mainly the job of this. This is a wrong pattern. So the patient will come with pain all over. You need to know exactly which muscle is the prime muscle that has caused the problem, and that comes to your proper assessment. And then you zoom down on the problem. So yeah, I know it is the supraspinatus that created the problem. Then we will apply the protocol. The protocol simply works like this. Let me tell you about it quickly, then I'll go to the other room and we will see it live with our case study. We'll find the muscle. Let's say, let's go to the easiest one, the one that is biceps tendinitis. We have front muscle, biceps, overactive and tender. We have the triceps, underactive, could be tender, could be not, you don't know. We test the biceps muscle. It is strong. Like I said, it doesn't mean anything. It just means that, like the number one in the equation, it is a strong muscle, but it doesn't mean anything until I put it into the proper equation so that I can get the good result. Then I'm testing the triceps. I found the triceps is weak. So we'll identify this muscle or muscle groups, the shoulder flexors per se, as A, group A. We will say that the triceps or the shoulder extensors are as group P, okay? So we have tender muscle, strong in the clear. We have weak muscle in the clear. And how to find if there is a relationship between both, we will do what we call we'll do what we call therapy localization. نعمل حاجة اسمها therapy localization. دي حاجة جديدة. كان أول concept طلع لحاجة اسمها therapy localization كان بالدكتور Goodhart, the father of the applied kinesiology. And applied kinesiology is a very, very bad. It's not exercise kinesiology way. It is techniques, like specific techniques used to mobilize different parts in the body. So therapy localization, if you are to test a strong muscle, sorry, a weak muscle. So let's say that the triceps is weak. Then if I'm to put my hand there and test the triceps and it gets stronger, this is the therapy localization. You put your hand on the area that is most tender on the strong, overly active muscle and test the paired muscle, which is group B, like we said, against the resistance. If this changes the strength, so if you test the triceps, it's weak, then if you put your hand there and test the triceps, or have the patient put his hand there and test the tricep and it gets strong, there is a relationship between those two muscles. And that's the therapy localization. It is simply altering the sensory stimuli going to the brain through this muscle. We know that touch sensation are the highest, fastest one that's transmitted to the brain. So we're trying to have the brain calm down this muscle so that it gives a chance for the muscle that's paired with this overactive muscle to work. And if you found a relationship between these muscles, provided that you did the steps, you find group A muscle, group P, tested group A, strong in the clear, group P, weak in the clear, you did the TL and tested group B and it gets stronger. So there is a relationship between those two muscles. So you've identified the pattern now. دلوقتي انت خلاص في مشكله، انا عرفت الاثنين اللي مسؤولين عن المشكله هما الاثنين دول. خلي بالك احيانا ما تبقاش بس عضلتين، ممكن يبقوا 3 أو 4، بس مش ده موضوع التوبيك بتاعنا النهارده. ده زي ما قلت ده بنتكلم عنه اكتر في الكورس بالتفصيل. عندنا كورس على يومين 8 ساعات، كل يوم على 16 ساعه توتال، فبنتكلم براحتنا عن ايه الحاجات اللي ممكن تشوفها اللي ممكن تغير الريزلت او التستنج ريزلت بتاعتك. Anyway, so we identified the problem here between the biceps, A, group A, and triceps, group B. We did the TL. We found a relationship. What is the next step? The next step is simply you fix the problem, release the tight muscle because you need to calm it down because it's overworking. The brain has recruited it too much to the extent that is painful and tight. So you need to release it. Releasing it will be any release technique, active release, cupping therapy, acupuncture, soft tissue release, ultrasound, laser, whatever the technique you feel comfortable to do, then you will activate the muscle that is weak, that is tested weak. You need to activate it to restore the balance. And this should be done within a window of 5 to 10 seconds of the release, because this is the window that the brain will give us to insert the new learned motor pattern. So the brain is recruiting the biceps, forgetting about the triceps. That's the new motor pattern. So you need to reverse this. Okay, you're talking to the brain, hey, I need to activate the triceps in conjunction with the biceps, please. So any movement that includes the biceps, please activate the triceps, do not ignore it. And that's what I'm trying to do. I'm trying to reprogram a new motor pattern, which is the correct one. It should be done at this area based on my assessment. And you will do this for as long as it takes to release the muscle and activate the muscle. Simply, there are so many activation ways. I'll talk about the simplest one, just very mild resistive exercise, just to get the muscle engaged. Then you finished half of your protocol now. The other half of the protocol will be retesting. I need to know if what I did has worked or not, because you might be wrong. You might be in the wrong bears. You might be wrong in the wrong muscles, although you've tested them and they've proven that there's a relationship, but it is not the primary relationship. There's a bigger relationship between another muscle and this muscle that supersedes your current muscle that I have chosen, like the triceps. So you will redo the testing. So how's that? You will retest the muscles against each other again. So you go test muscle A, then you test muscle B. If it is strong, then your technique worked. Good for you. Then you'll send the patient with the exercises home based on your assessment and treatment. If it doesn't work, you might try it again for a second or third time. You've got a maximum of 3 times of repeating the treatment. If it stays, good. If not, then you're on the wrong muscles relationship or the wrong pattern. You need to reassess your way, reassess the muscles because you didn't zoom down. You're not zooming down on the proper relationship. This is simply the protocol. You send the patient with exercises. Like I said, okay, how many repetitions? How long the patient will do the exercise? That's what you're going to test. So after you did your successful protocol, you test the patient, push my hand, please, against the resistance, and you hold it and you count 1, 2, 3, 4. Then you start to find the muscle shake now. You find the patient, oh, you know what? It hurts now. Then that's when you need to stop. So if the patient said after the count of 6, oh, I start to feel pain. So you send the patient with only 4 seconds of hold or isometric exercise. If the patient stayed till 10 seconds, 20 seconds, that's your time. And the patient will repeat it as long as you feel it is more convenient and comfortable for the patient to be done. This is simply the protocol. It's called the differential testing protocol. We use it to any part of the body. We use it for any joint of the body. And that's the beauty of this technique. We use it with any muscle, ligament, joint in the body. We use it for the upper extremities. We use it for the lower extremities. We use it for the spine. We use it for the core. We use it for the neck. We use it even with the pelvic floor muscles, patients with stress incontinence or rectal herniations or any other problems. We can implement, we can implement this technique. I'll talk about the myofascial lines because that's the revolutionary method now of thinking. Before, we used to think that the body is separated. We used to study anatomy. I do remember very well, okay, here is the upper extremity. This semester is about the upper extremity. Next semester is about the lower extremity, and so on. So we've inherited the idea that, okay, the body is different. I'll talk about the upper extremity, then I'll talk about the lower extremity. So if a patient comes with a shoulder problem, oh, I'll have to look into the shoulder and fix it. If the patient comes with a back problem, I need to look into the back and fix it. That is not correct. Now, the body is one unit. The body is like your bed sheet. If you have a good, well, clean, tidy bed sheet in your bed, then you come to the edge and pushed it, it's gonna be distorted at the very opposite end, right? So لو حضرتك عندك ملاية السرير وشدتها من طرف، الحتة اللي انت عندها دي هتكرمش هتبوظ، وفي نفس الوقت الناحية التانية برضه. ده نفس الشيء. معنى ان عندك مشكلة هنا مش معناها ان المشكلة اللي حاصلة في الآخر دي مش مرتبطة بالمشكلة دي. It doesn't mean that if you pulled it from here and it curled or crumpled, that the problem at the other end of the bed sheet is not related to that. They are related. And that's the beauty of MKT. We utilize the myofascial lines a lot in order to get corrections or get a relationship between different body parts. كان عندي حالة, let me just move out a bit. I have a case in VA. She had a problem in her neck. Her neck was like, she can't lift it. If she's lying supine, she cannot lift her head up. ما تقدرش ترفع راسها. لو نايمة راسها ما تترفعش. She must do this in order for her to raise up. So she was seen by another physiotherapist, and each and every physiotherapist and a chiro and a massage therapist used to work in her neck. Until I saw her, then I started my assessment. My assessment is a bit different than any other assessment because, like, I don't want to say it again, but in the course, we'll see how do we assess the whole body instead of just assessing just one part of the body. احنا بنعمل assessment تقييم بتاع العيان كله. لما العيان بيجي لي العياده انا بيشتكي من الشولدر، اوكي انا بعمل assessment بتاعتي للشولدر مفيش اي مشكله، بس عمري ما بنسى بقيه الجسم. لازم ابص على the other. I have to look into the other body parts and joints because, like I said, remember the bed sheet example. If it happens here, it's going to affect somewhere else. And that's the good thing about the MTT. It teaches you that the body is one unit. So this patient, when I saw her, sorry, I did my assessment and I found that the problem is not from the neck at all. Her neck muscles are weak, but it's not from the neck. It's because the anterior frontal line, I hope it's, yeah, the very right one, the superficial frontal line, if you can see, it is the neck muscles. And if you go the blue lines there, it goes down to the abs, the abdominal muscles, it goes down to the quadriceps, then the anterior tibial group and the toes extensor. And that's what I found with this lady. She had the anterior tibial group compensating or doing the job or overworking for the neck flexors. Same like the example that we said, group A and group P. The biceps was overworking for the triceps and hence the triceps wasn't working. The same thing here. Her neck flexors weren't working because of the injury that she had during the car accident. And the body, the brain, will try to find a way to just get yourself up and walking. So what I'll do, look into the frontal line, recruit the nearest, the easiest muscle to be recruited, which is the anterior tibial group, which are the ones that work alongside the neck flexors. So they are in the same line, myofascial line, so let's recruit them. And that's what happened. Once I started addressing this specific relationship, in the very first visit, the patient cried because she said, this is the first time I'm able to raise my head for so long if I'm lying down. She could raise her head, partially raising her head. It's not completely, because this was just the first visit. We need to do a lot of work to restore the mobility around the neck and to restore the strength of the muscle. And that's how good is that. You get to the bottom of the problem, you get to the root cause of the problem and fix it and get the job done. Okay, I'll take you guys with me. I'm in the clinic actually. Let's see what we can do in terms of practically practicing this protocol. We have a case here. كان بيشتكي من ألم من الرايت هيب جوينت، عنده رايت هيب جوينت في مشكلة لما بيجري لما بيمشي بيوجعه. حصلت معاه كذا مرة. حصل له ankle sprain وده اللي هنتكلم عليه. ليه لما يحصل hip joint يحصل ankle sprain? It is again the myofascial lines. If you need to fix a problem, find the root cause of the problem. لو عيان جاي لك العيادة بيشتكي من الانكل بين، مش شرط يكون المشكلة في الانكل، ممكن تكون المشكلة في الهيب، ممكن المشكلة في knee joint. You need to know where to start to fix the exact problem instead of just chasing the obvious. Or لما العيان يجي لك العياده وتعالجه كذا مره وما يخفش او ما يتحسنش بالتحسن المفروض ان هو يتحسنه، يبقى انت مش على المنطقه. You are not in the right spot. You're not targeting the root cause of the problem. انت مش قادر توصل للسبب الرئيسي للمشكله وتعالجها. And in MKT we have the tools, we have the methods that will enable us to address such issues and get down to the root cause of the problem. So lay down, please. So we have a problem. He complains always of pain in this area, which is the area of the gluteus medius and tensor fasciae lata. So it is the hip abductors, and it's been painful for a while. Whenever he runs stairs or if he just accelerates his walking, it hurts. So that's the common problem that a patient would come to you to the clinic. I have this pain. So doing your proper assessment, again, it doesn't mean that this is the problem that I'm gonna fix. It could be not. So I need to use my tool or toolbox, which is the MKT, to know if this is the one that I need to address or is it coming from somewhere else and this is just trying to compensate for it. So we'll do our assessment, the range of motion. Okay, can you bring your leg up, please? Down, any pain? Okay, bend your knee up. Yeah, any pain? No. Good, move your leg out, in and out. Any pain? Yeah. So range of motion is good. Just to save you time, I did the orthopedic testing. There isn't any pathology. I did the hip scoring test. I did the figure 4, all the compression distraction tests are negative. Ligamentous tests are negative. Mobilization, anything is negative. So it's purely muscle issue or muscles imbalances. So for me, I'll go and do my palpation scales to see which part of the muscle is more tender. Okay, how's that? Pain? You can see his face. His face is like this. Here, less, more? More here? Okay, so this is exactly like about an inch above the greater trochanter, which states that it's hip abductors, mainly the tensor fasciae lata, which is a main contributor to the hip abductor. Hip abductors are the tensor fasciae lata, gluteus medius. They all both work together. They have the same almost nerve supply, the superior gluteal nerve, L4, L5, S1. They do the same action, hip abduction. Internal rotation, some research that they said they participate in some degree of flexion, especially the tensor fasciae lata, because it has some anterior fibers that come from the anterior superior iliac spine that are inserted in the iliotibial band. Anyway, we're not going to be more specific. That's not the topic of this lecture, but we say that it is the hip abductor. To test the hip abductor, so always I'll go with the antagonist. So we have options to go with the antagonist, to go with the synergistics, or to search in the whole pattern itself or the myofascial line. So we start small, then we grow bigger. So we'll test this. Always it is hip abductors to hip adductors. Like this is very common, unless there is something else that is suspected that might have contributed to that. So I'll go and palpate the hip adductors to see if there is any tension there. Because remember, if there is a problem, if there is a muscle issue, tender muscle, there is another muscle that could be tender. So why not to check? Okay, bring your leg out. How's that? Okay. Here. So here it hurts really bad. So this is on the adductor longus magnus area. So let's say the hip adductor. So it is very tense there. It is even more painful. His face went like red more than when I touched here. So there is tight here and tight here. So I don't know which one is the overworking, which one is the underworking. So I'll do my muscle testing and to see which one is active or overactive, which one is weak. Okay, bring your leg up. Hands down, please. Okay, push my hand down. So this is weak. Push. He cannot sustain the pressure. And again, I'm not pushing hard. It's very, very minimal pressure. So hip abductors are weak, tight, and painful. This is the first information. What does it mean? So far, nothing. It's like the one number in the equation. I have just collecting the information. Okay, I'm gonna test the hip adductors. Okay, hold your leg. Good, again, cool. Very strong. Okay, so let's gather the information. I have hip joint pain. I have pain in the hip abductors, namely tensor fasciae lata. I have pain in the hip adductors. I've assigned group A abductors, weak in the clear, group B abductors, strong in the clear. In order for me to find a relationship, so this is the overworking muscle, facilitated. This is the inhibited underworking muscle group. So to find a relationship, we'll do the TL or therapy localization. If it's turned strong, so there is a relationship between them both. So here we go. Okay, turn it in, push out. It is weak. So what I'm gonna do is I'm gonna ask him to put his hand where it hurts. Can you put your hand there? Push. You see the difference. Take your hand down, push, nothing. Put your hand, push, it is strong. To prove this, I'll have him put his hand in a different muscle group. Okay, put your hand here. Push, nothing. Okay, put your hand on the other leg. Push, nothing. Put your hand on the painful part, push, and that's how different is that. So my next step would be releasing this muscle. Like I said, anyway, I'll just go with soft tissue now, or active release. I prefer active release, actually. Okay, relax. I know. It's gonna be painful, by the way. It's not gonna be a lovely thing. So you need to be careful if you are dealing with sensitive people. Is it painful?
Really, really bad.
Okay, sorry about that. I'll buy you coffee after.
Fine.
Okay, I did a release. It's not that enough, but it should be enough to give me a result. Hands down, please. Hands down. Okay, push. You see the difference? That's how different is that. So to finish up our protocol, I need to see if whatever I done holds or not. So hold your legs. Don't let me push. Nice, good, strong. Push out. It is better. Let's see the pain. How's that?
A little bit of pain.
Little, less than before or same like before?
Less.
Less than before. So we did like a minute of release. Obviously, we need to go back and do more release. So we will do this a few more times. Like you see, I didn't touch this because that's not the root cause of the problem. The root cause of the problem is here. And if I'm to spend more time releasing this and activating this, he will walk out of the clinic without pain there at all. And he got an ankle pain before. I just checked his ankle before. How's that? Less than before. Yeah, I just checked the ankle before doing this. It was painful. Now it's less. So it worked. So here's what we'll do. We'll do this. We'll send the patient home with the same routine, just releasing this muscle, please. And the activation would be as long as the patient is able to hold the muscle against your resistance. That's his homework. And that's how he's going to be doing it at home. That simply is the protocol that we are utilizing in the clinical practice. It could be different than this a bit. It depends on how many muscles are involved in, in the relationship. Like I said, it's not only just as simple as that. It's sometimes, and many times, it is a bit more complicated than this. And again, this is the steps that we need to do. The assessment, you find your dysfunctional relationship, confirm with testing, fix the problem, reassess, and homework, which is the third pillar of what we do. We can use this with the core muscles, the rectus abdominis, transversus abdominis, QL, psoas, lumbar extensors, erectors, hip joint muscles, including all the hip joint muscles, adductors, abductors, glutes, external rotators. And one important point in the course, not in this lecture topic, I can talk about it later if you want, in a separate lecture. Scars are very, very major contributor to the dysfunctional pattern because the brain views those scars as injuries or insults to the nervous system and hence creates strong motor pattern around those areas, because brain sees this as an injury. Surgery or not, that's not what the brain is concerned about. The brain is concerned about creating the proper pattern. So the brain will try to avoid the injured area via recruiting other muscles around it or in front of it or far from it. It depends on your assessment. Then your job is to find the relationship of the scar to those muscles and fix this relationship. Again, we'll talk. So this can be used, again, in the course, we test all these muscles, we practice them, we find like live examples from the participants. If there is a dysfunctional relationship in anyone, all the people have hip pains, all people had knee pains or ankle pains or back pains. So it's not a big deal to find someone with dysfunctional relationship in those areas. We deal with the ankle, foot muscles, we deal with the neck muscles, which is a bit more complicated than the back even, shoulder muscle, all the shoulder muscle, we deal with them, elbow, hand, and wrist.